For this presentation, we will be discussing different respiratory disorders. You need to pay close attention to what pages and chapters these disorders are on. We will cover asthma, which is in Chapter 33. The rest of the respiratory disorders will be in Chapter 37. Just a brief A&P overview. Your book goes into great detail about the differences between the adult and pediatric airways. Pages 665 and 666 you should read and understand why children are more at risk of developing an obstructed airway. The underlying cause of almost all lung disorders in children is airway obstruction. So why is it easier for a child to have an obstruction than it is for an adult? So airway resistance is greater in children when compared to adults. The chest wall is more compliant, which increases risk of obstruction, and babies are obligatory nose breathers. So it's easy for their airway to get obstructed by a foreign body, mucus, or inflammation. Materials such as secretions, tumors, foreign bodies can cause swelling. They can also have hypertrophy of the glands in the mucosa. They are at risk for airway spasms or bronchospasms, and extrinsic compression can also lead to airway obstruction in children. So first up, we're going to talk about coughing in children. Coughing is a reflexive response of the lower respiratory tract to the stimulation of cough receptors in the airway mucosa or from an irritant. You need to know the associated symptoms with which, along with a chronic cough, can mean a serious lower respiratory illness. And this chart just kind of gives you a breakdown of what type of cough each disorder is going to have. If you have somebody with bronchitis, asthma, or cystic fibrosis, they may have a loose, productive cough. Tracheitis or Habit cough may have a brassy type cough. If you have somebody with stridor, that usually is some type of medical emergency because that means they're not maintaining a patent airway. What coughs are going to be more at night: upper respiratory infection, allergy, sinusitis. Worse in the morning would lead you to believe they may have some bronchiectasis, and cystic fibrosis patients have cough worse in the morning. First, we'll talk about wheezing. In infants and young children, wheezing occurs because of age-specific anatomic and physiological properties. And this involves any pathophysiologic process resulting in impaired airflow caused by a reduction in airway diameter. Most common cause in infants is a viral infection or viral illness and asthma. Virus-specific factors: the ability of viruses to affect the lower airways, induce IgE antibodies, and cause cytokine responses. Host-specific factors that cause wheezing: lung size, parental history of asthma, the atopy triad, and exposure to cigarette smoke. Important questions to ask yourself when examining a baby or child with wheezing: is the wheezing in conjunction with stridor? How does the child look overall? Do they look sick? Are they having to work harder to breathe? Is the wheezing in conjunction with crackles, or what other lung sounds do you hear? Where is the wheezing heard the best? Is it on inspiratory? Is it on expiratory? Where is the child plotting on the growth curve? Other key points to remember: about 60% of infants who wheeze will outgrow it, but about 15% will have persistent asthma. Next, we're going to move into asthma. Again, this is in Chapter 33 on page 523. Asthma is defined as a multifactorial chronic respiratory condition. There are several key features that you need to keep in mind when you're talking about asthma. Number one would be the immunohistopathology. First starts with airway epithelium being shed and collagen deposited under the basement membrane. This causes edema to occur, and then mast cells are activated, and then this leads to inflammatory infiltration of eosinophils lymphocytes, and neutrophils. These cells fill the airway and then infiltrate the epithelium, which leads to airway lumen damage. Next, airflow limitation is caused by acute constriction of the bronchi, airway edema, and then obstruction, which is a mucus plug leads to obstruction, which leads to increased resistance to airflow and decreased expiratory flow, which leads to a decreased expelling of air, and hyperinflammation, which in children, they have limited compensation, so when the tidal volume reaches the volume of pulmonary dead space, it hyperinflates the lungs. This leads to overdistension, which is a compensatory mechanism which maintains the airway patency and causes alveolar hypoventilation and leads to a ventilation perfusion mismatch, which causes the symptoms of asthma.
This is just an overview of what happens during an asthma attack. There's a narrowed airway with limited airflow. The muscles tighten and constrict the airway, and the airway wall becomes thickened and inflamed. Clinical manifestations of asthma in their history, associated conditions, chest tightness or dyspnea, cough, pattern. Is there a pattern to the signs and symptoms? On physical exam, you're going to hear wheezing, prolonged expiratory phase, a high-pitched rhonchi, decreased breath sounds. They can have signs of respiratory distress, tachycardia, hypertension or hypotension, cyanosis, or atopic symptoms. It's important to know if a patient is suspected of having an asthma attack and you do not hear wheezing, this is an ominous sign, as this indicates severe airway obstruction.
So this first table is the classification of asthma in children 0 to 4 years of age. There's a different table for different age groups. You need to review table 33.2 on page 524. There's also figures 33.3 and 33.4 that are important to know. You need to know each classification, intermittent, mild, moderate, severe, because this tells you what medication you're going to start them on and how you're going to progress. If you look at the table, intermittent symptoms occur less than 2 days per week. They don't have nighttime awakenings. Their short-term beta agonist use is less than twice a week. It doesn't interfere with their normal activity. And then this progresses as we move through the stages, which once you get into mild, it's considered persistent. And then you go to moderate and severe. Severe persistent asthma, they have symptoms throughout the day. Nighttime awakenings at least once a week, sometimes more than that. They have to use their short-acting beta agonist at least several times a day, and their activity is extremely limited. Same thing with this. This is for children ages 5 to 11. And you move from intermittent to persistent, mild, moderate, severe. You need to know how each are classified. The intermittent is about the same as the intermittent in children 0 to 4, except they may have nighttime awakenings that are less than twice a month. And again, this tells you what medicine you're going to start and when you're going to move to the next medicine. All asthma treatment is a stepwise approach. When you get to step 3 is when you need to refer patients, whether they're children or adults, to a pulmonologist for further treatment and evaluation. This chart will be for children 12 years and older. And again, it's basically the same as we move from intermittent to persistent into severe. Again, you need to know the symptoms that are associated with each age group.
So how do you diagnose asthma? So pulmonary function tests, formal spirometry is the gold standard for diagnosing asthma in children greater than 5 years of age.
Next, we're going to talk about the management of asthma. This is where most students have a difficult time. First, you need to learn the classification for each age group, and then look at the management to see where your patient falls, and then this determines what you're going to treat them with. Okay, you need to be familiar with this table. Figure 33.1 on 529 and figure 33.2 on page 530 in your textbook give age-specific asthma management guidelines. Again, I said this earlier, but you need to consider referral to an asthma specialist if you get to stage 3 or higher in your treatment plan. Other things to remember is, with chronic asthma, they need to learn what causes it. So what is it, an allergen or some kind of irritant that causes it, and they need to be educated to avoid those. They need the flu vaccine yearly, and then you're going to treat other associated signs and symptoms appropriately. With an acute asthma exacerbation, you're going to treat that based on the severity of their symptoms. You're going to use a stepwise approach based on the classification, which I said earlier. And remember, refer to an asthma specialist or pulmonologist if you get to stage 3 or higher in treatment. We harp on patient education with every disorder. Asthma is especially important because these patients can get into a lot of trouble at home if them or their parents are not educated enough. You need to educate on the disease process and how it's going to progress. Educate on the importance of compliance with treatment. Controlling environmental allergens as much as possible is important. You also need to instruct on medication instructions. Do not assume your patient or caregiver knows how to use an inhaler, knows how to use a nebulizer. You need to instruct specifically on how to do that. In a lot of clinics, you'll see they have empty inhalers, empty injection pens, things like that they can show the patient and the caregiver how to use those. They're very important to use. Do not assume your patient or your caregiver understands how to use these things. Okay, you need to educate. Home PEF monitoring is a good thing. Plan for worsening symptoms and how to manage asthma when they're away from home on vacation, etc. You need to get a treatment contract with asthma patients and the caregiver, and this should outline what the current treatment plan is, what symptoms to monitor for an acute exacerbation of asthma, and what are they going to do when the patient has an acute exacerbation. Okay, this all needs to be typed or written and given to the patient and the caregiver so they can refer back to it at home. Next, we'll move over to acute bronchitis. We've probably all had bronchitis at some point in your life, or you have already seen patients with bronchitis. It's almost always viral. It can cause a secondary bacterial infection, though, but usually bronchitis is caused by a virus. You need to treat with antivirals if influenza A is the cause, and you need to treat with macrolides if pneumonia or if M pneumonia or C pneumonia are the cause. Prominent features or signs and symptoms include an initially non-productive dry hacking cough, a low grade or no fever, and rhinitis. Supportive care is important. It's a virus, as we said. Humidifier to help open the airways, help them breathe better, but you're really just going to do supportive symptomatic treatment with no antibiotics. You can use nasal sprays, things like that, if they're having a lot of rhinitis symptoms. Cough suppressant would be a good idea with them because it's usually non-productive. They don't have anything to get up because it's upper airway. So you can do cough suppressants with these things. Next, we're going to talk about bronchiolitis or RSV. This is a lower respiratory tract disorder characterized by inflammation leading to obstruction and swelling of the small bronchioles. This also leads to decreased expiratory flow. It can be characterized by necrosis and sloughing of epithelial cells into the airway as a result of infection of the bronchiolar epithelium. It is most commonly caused by RSV. Other causes can be implicated as well, but usually it's caused by RSV. The incubation period is 4 to 6 days. It's most common in the first 2 years of life. It is spread by close contact. Risk factors include being premature babies get it more often. a chronic lung disease, and immunodeficiency. Usually a baby has been exposed to an older family member with an upper respiratory infection. That's important to know.
So they're usually going to start with a URI initially, then they gradually develop respiratory distress, low-grade fever, decreased appetite. You're going to hear paroxysmal wheezing, crackles, tachypnea. They're going to have signs of respiratory distress. Sometimes they have a palpable spleen and liver. Management, supportive care, parent education. A lot of times hospitalization is indicated. Humidified oxygen. They're going to need pulse oximetry to monitor their pulse ox. A trial of bronchodilators. In some cases, home oxygen may be needed. They need to stay very hydrated with IV fluids or parents forcing fluids, and nasal suctioning is very important.
Next is croup. If you have never heard a baby with croup, it comes with a very distinctive cough. They sound like a seal when they're coughing. So if you hear somebody with that seal type cough, you'll know it. And this is defined as an acute upper airway inflammation. It's almost always viral. Parainfluenza causes 75% of cases. It's most common in children 3 months to 5 years of age. The duration of the illness is usually about 5 days. Signs and symptoms: stridor, barky cough, dyspnea, tachypnea, low-grade fever, decreased breath sounds with rhonchi. Diagnosis usually clinical. If in doubt, you can get an x-ray and you're going to see the steeple sign, which is pictured beside the text. Management: symptomatic. You need corticosteroids, humidified air, an epinebulizer, oxygen if needed. These patients, you can tell the mom or dad, whoever the caregiver is, to take them in a bathroom, turn the water in the shower on as high as possible, and sit in there, and that warm, moist heat can help open their airways to where they can move air better. You need to know when to hospitalize. On page 680 in your textbook, it goes into details about this. If a child has severe respiratory distress with severe retractions, if they're having stridor at rest, or signs of other conditions, or they're not improving with standard treatment, children need to be hospitalized. If you work in family practice or in a pediatric clinic, you may come across this. So you need to know when to hospitalize when it comes to all conditions, but respiratory conditions, because of the things we talked about in the A&P section, these patients can get into respiratory distress pretty quickly. So if they're not getting better and you can't admit, then send them to the emergency room for admission. Next, we'll move on to epiglottitis. This is defined as an acute inflammation of the epiglottis and the supraglottic larynx. Physical exam, you're going to see acute onset of stridor, drooling, muffled voice, high fever, nasal flaring, and they're going to get in the tripod position. Occurs in kids between 1 and 5 years of age. It's commonly caused by H. influenza. These kids look sick. I've said it in another lecture. Sick kids look sick, and these kids come in and you can tell they're sick just by looking at them. Okay. You're going to treat with oxygen and broad-spectrum IV antibiotics. This is an emergency, and you need to get them to the emergency room via ambulance if you are not very close to hospital. Even if you are close to the hospital, you may want to send them via ambulance. They're going to get blood cultures. An x-ray may show the thumb sign, and you'll see a picture of that on the next slide. If these patients are transported to x-ray, somebody needs to be there that can intubate if necessary, because these children will get into respiratory distress very quickly. If untreated, this has a very high mortality rate because their airway will completely close off. Next, we're going to talk about cystic fibrosis. This is defined as an inherited multi-system disorder involving the lungs, GI tract, and exocrine glands. It's important to know which systems it affects and what symptoms it causes. some hallmark characteristics of cystic fibrosis is obstruction and infection of the airways, poor digestion, and dysfunction of the epithelialized surfaces. Diagnosis is made from abnormal sweat tests. Greater than 60 milliequivalents per liter of chloride on 2 different specimens is considered diagnostic. In the lungs or respiratory tract, it causes cough, purulent mucus, bronchiolitis, pneumonia, nasal polyps, and sinusitis. In the GI tract, it causes a meconium ileus, and it can also cause failure to thrive secondary to pancreatic enzyme insufficiency, steatorrhea, poor muscle mass, and recurrent acute pancreatitis. In the GU tract, it causes delayed sexual maturation and infertility, and in the exocrine glands, it causes excessive salt loss, hypochloremia, and dehydration.
Pneumonia is another big one. It's defined as inflammation of the lung parenchyma caused by numerous things. It can be bacterial or viral. Those account for 85% of community-acquired pneumonia. Risk factors: lung disease, anatomic abnormalities, GERD, neurologic disorders, and immunodeficiency disorders. There's multiple types. You can have lobar, interstitial, or bronchopneumonia. Microorganisms such as viral, bacterial, fungal cause pneumonia. You can have non-infectious causes such as foreign bodies, aspiration, or hypersensitive reactions. You need to know how to distinguish between the types of pneumonia.
Next, we'll move into the pneumonias. It's defined as an inflammation of the lung parenchyma. It's caused by numerous things. Bacterial and viral causes account for about 85% of cases of community-acquired pneumonia. Risk factors include lung disease, anatomic abnormalities, GERD, neurological disorders, and immunodeficiency disorders. There are 3 different types. It can be lobar, interstitial, or bronchopneumonia. The pictures here are a comparison of normal lungs on the right and lungs with infiltrates that are suggestive of pneumonia on the left. Bacterial pneumonia is when bacterial invades the lung parenchyma. The disease process is determined by the pathological organism, and each organism affects the lungs differently. Primary bacterial pneumonia is less common in childhood. Often bacterial pneumonia is a secondary infection after a viral infection. Symptoms usually they'll have an acute onset of upper respiratory infection symptoms that progress to worsening cough, chills, fever, and this may be a higher fever of 102 or more, dyspnea, tachycardia, rales, decreased breath sounds, grunting, and retractions. Labs, they'll likely have an elevated white blood cell count. X-ray, you may see lobar consolidation. Management, if you're going to treat them outpatient, if they're 2 to 3 months of age, if chlamydia is suspected, you want to treat with oral zithromax for 5 days or erythromycin for 14 days. If they're 3 months to 18 years of age, you want to do some amoxil 90 milligrams per kilogram per day, divided in twice-a-day dosing for 10 days. If it's community-acquired C pneumonia or M pneumonia, you want to use Zithromax 10 milligrams per kilogram per day once a day and on day 1, and then 5 milligrams per kilogram per day for 4 days. Next is mycoplasma pneumonia. This is a primary atypical pneumonia, or walking pneumonia is what you may hear it referred to. Signs and symptoms is a slower onset of bacterial pneumonia. They usually have persistent cough, malaise, headache, fever. It's the most common cause of pneumonia in kids 5 and older. It's transmitted by droplets from one person to another, and the incubation period is 2 to 3 weeks. You're going to get X-rays. They may have an interstitial infiltrates. They're going to have a normal CBC. Treatment is Zithromax or another macrolide. Complications, it can spread to the blood, central nervous system, heart, skin, and joints. Next, we're going to talk about viral pneumonia. This is common in all age groups. It can predispose patients for a secondary bacterial infection. Common signs and symptoms are usually a more gradual onset: cough, coryza, hoarseness, crackles, wheezing, stridor. Fever. Some causes include RSV, influenza, CMV, parainfluenza, adenovirus, human metapneumovirus and rhinovirus. Labs are usually normal or maybe a slightly increased white cell count. X-rays, you're going to see transient lobar infiltrates. Management is usually supportive care. You only treat with antibiotics if you think the patient has developed a secondary bacterial pneumonia. Otherwise, you're just going to do symptomatic treatment with these.
This chart breaks down the differences between bacterial and viral pneumonia. Again, bacterial is an acute onset. They have a high fever and chills, URI, cough, dyspnea, tachypnea, rales, decreased breath sounds, grunting. The kid is going to look more sick with bacterial pneumonia. You're going to have an elevated white count, lobar consolidation. In viral, they have a more gradual onset. The fever is usually lower. They have a cough, coryza, hoarseness, crackles, wheezing, stridor. They have a normal to slight increase of white count, and they're going to have transient lobar infiltrates on an x-ray. Notes about chest x-rays. Early on during pneumonia, x-rays may appear normal. Later on, you'll see the infiltrates. Hyperinflation is commonly seen in x-ray during viral pneumonia. Follow-up x-rays are needed if there is no improvement, persistent cough, or dyspnea.